morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Rajshekhar Chakraborty from Colombia, and he's going to lecture us on bispecifics for treating multiple myeloma. This webinar is brought to you by Mumbai Hematology Group, supported by Jensen, Natco Oncology, Lucien Life Sciences, and Nirvin Life Sciences, and managed by Perfect Square. I thank Team Jensen, Natco, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Rajshekhar Chakraborty from Colombia. All our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 18th of August 2024, from 11:30 a.m. Indian Standard Time and 8 a.m. the Netherlands time, we have Dr. Rick Kapoor from Amsterdam, Netherlands, speaking to us on basics and applied aspects of immunobiology of ITP. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Colonel Ashok Meshram from Command Hospital, Kolkata, Dr. Aditi Shah Kaskar from HCG Hospital, Borivali, Dr. Ashish Dixit from Comprehensive Cancer Center, Manipal Hospital, Bengaluru, Dr. Chirag Shah from Apollo Hospitals International, Ahmedabad, Dr. Hamza Dalal from Fortis Hospital, Mumbai, Group Captain Dr. Harshit Khurana from Armed Force Medical College, Pune, Dr. Himal Shah from Cure Hematology Center, Ahmedabad, Dr. Jeevan Kumar Garg from Tata Medical Center, Kolkata, Dr. Kartik Kumar from AIMS, Rishikesh, Dr. Khushbu Jain from Medicover Hospital, Aurangabad, Dr. Kunal Chatani from Nagpur, Colonel Dr. Kundan Mishra from Command Hospital, Lucknow, Dr. Mayan Singh from BRAIRCH AIMS, Delhi, Dr. Nishant Dhakate from HCG NCHRI Cancer Center, Nagpur, Dr. R. Prasanna from Cancure Cancer Center, Tamil Nadu, Dr. Rahul Arora from RST Hospital, Nagpur, Dr. Roshni Bhagwat Pandey from Marble City Hospital, Jabalpur, Dr. Sachin Bansal from AIMS, Bhopal, Dr. Sadhna Sharma from AIMS, Patna, Dr. Sanket Shah from HOC Vedanta, Ahmedabad, Dr. Satish Kumar A from Manipal Hospital, Yashwantpur, Bengaluru, Dr. Shub Prakash Sanyal from Fortis Hospital, Mumbai, Dr. Sudhir Kumar Atri from Pandit Bhagwat Dayal Sharma, PGIMS, Rohtak, Haryana, Dr. Sundar Shevale from TMC, Kolkata, Dr. Tejaswini Guribande from RMR Road Park Extension, Max Super Specialty Hospital, Karnataka, Dr. Vipul Sheth from RGCIRC, Delhi, Dr. Vishwadip Khushu from AIMS, Nagpur. Now it's time to introduce our guest speaker for the day. We have with us Dr. Rajshekhar Chakraborty from Colombia, USA. Dr. Rajshekhar Chakraborty is MD and is Assistant Professor of Medicine at Columbia University Irving Medical Center in the Division of Hematology and Oncology. After receiving his medical degree from University of Delhi, India, he completed his residency in internal medicine at Icahn School of Medicine at Mount Sinai Queens Hospital Center. Subsequently, he spent 3 years as a clinical researcher in plasma cell disorders at the Mayo Clinic, Rochester, followed by fellowship in hematology oncology at the Cleveland Clinic. He primarily cares for patients with plasma cell disorders, including multiple myeloma, amyloidosis, MGUS, Boehm syndrome, and Waldenström macroglobulinemia. His research interests include clinical trials and outcomes research in plasma cell disorders. And today he's with us and he's going to lecture us on bispecifics for treating multiple myeloma. Well, thank you so much. Over to you, Dr. Rajshekhar Chakraborty.
Thank you very much, Dr. Khurana, for the kind introduction. And in the interest of time, we will go ahead. Before starting, I just wanted to take a moment expressing solidarity with doctors all over India who have risen to the moment to protest against the unsafe workplace, especially for female physicians. And I sincerely hope that the authorities will take steps to ensure justice for the deceased, and not only that, but also long-term structural solution to improve workplace security for doctors in India. With that, I will share my screen to get started. Just a second. Khurana, you can see my screen, right?
Yes. Can you please put in the full screen mode?
Yes, I'll put it in. All right. So today we will talk about updates on bispecific antibodies in multiple myeloma and AL amyloidosis. These are my disclosures. So I'll start with a case. Let me move the cursor here because it's covered. Okay. So I'll start with a case. So there's a patient I saw in the clinic now a couple of years ago. So 68-year-old male who was referred to our clinic for relapsed refractory IgA lambda multiple myeloma. He was RISS stage 3 with T414. So you can see that patient was high risk at diagnosis. He was diagnosed approximately 6 years ago. At that time, he was treated with VRD, followed by a MEL200 autotransplant, followed by LEN maintenance. He had a first remission that lasted about 3.5 years, and then he relapsed with new bone disease on PET scan. Subsequently, at that time, the standard of care for first relapse in the US was daratumumab carfilzomib dex, so he got started on that. However, the remission lasted only about 1.5 years, and then he relapsed again with more FDG-avid lesions on PET scan. And at that time, he got pomalidomide, Cytoxan, Dex, but the remission lasted very short. It was approximately about 6 months. And then there was a fulminant relapse. And at that time, when we saw the patient in our clinic, he was relapsing with worsening anemia, thrombocytopenia, and multiple FDG-avid lesions on PET-CT. So in summary, this patient was a high-risk triple-class refractory, that is PI, IMiD, and anti-CD38 antibody refractory patient with multiple myeloma. And the question is that assuming the patient is fit, let's say ECOG1, and willing to get additional treatment and otherwise has no major comorbidities, what therapy would you choose next for this patient, given that he has kind of exhausted pretty much most of the myeloma treatments, including PI, both PIs, then IMiD and anti-CD38 antibody, and he already had gotten one autotransplant, and the remission after the first autotransplant with maintenance was 3.5 years, so was not very impressive. So, it's hard to say whether the patient will benefit from a second auto transplant or not. So what therapy would you use next? So basically, with that segue, I just wanted to show this that why this patient population is important, because the patients with triple class refractory multiple myeloma, they usually have very, very poor outcomes. And this was an analysis done by Dr. Susan Ball from the University of Alabama in the US. And it was a multi-center retrospective cohort study. And as you can see, patients with triple class refractory multiple myeloma, no matter what you use in those patients, the median progression-free survival is only about 3 months, and the median overall survival is less than a year, is only about 9 months. And this was before the era of bispecific antibodies or CAR T cell therapy. So this is a true unmet need. And even in the US, we did not have any good treatments once patients were triple class refractory, and most patients would rapidly progress through the remaining treatments if you were to use some of the older treatments like VD-PACE, etc. And their overall survival would be less than a year. So this is a true unmet need, and we are so glad now to have some really good treatments in this space. Going to the, yeah. So, with that segue, I'll move to the bispecific antibodies. So, what are bispecific antibodies? So, basically, bispecific antibodies, they are also called as TCE or T cell engagers. So, we think about them as like matchmakers. So, they basically, one arm of their bispecific antibodies binds to an antigen on the surface of the tumor cell, in this case, BCMA or B cell maturation antigen on the surface of the myeloma cell, and the other arm binds to CD3 on the surface of T cells. And this creates a transient immune synapse between the T cell and the plasma cell, which subsequently leads to perforin and granzyme released from the T cells and causes target cell death. So it basically brings the multiple myeloma cell and T cell together, the endogenous T cells, as opposed to the CAR T cells, where the endogenous T cells are harvested and then they are sent for engineering to express the chimeric antigen receptor and then infused back. Bispecific antibodies are basically off-the-shelf products. If you want to start the patient on treatment tomorrow, you can start it tomorrow. So that's kind of the benefit of bispecific antibodies over CAR T cell. So currently, there are three major targets of bispecific antibodies in multiple myeloma: BCMA or B cell maturation antigen, GPRC5D or G protein coupled receptor, G protein coupled receptor group 5 factor D, if I'm correct. And then the other one is FCRH5. So I have highlighted the BCMA and GPRC5D here because these are the two which are FDA approved, whereas FCRH5 is still not FDA approved, is still in clinical trials even in the US. So most of the talk today will be focused on BCMA-targeted bispecific antibodies in multiple myeloma because those are the ones which are FDA approved and we have the most data on. And I will structure the talk into the five key subtypes. So the first is, what are the agents currently approved or in development? What are the unique features of each agent? Do these agents differ from each other? How does the efficacy of these agents compare with each other? What are the toxicities and what are the unanswered questions in this field? So first, let's talk about what are the agents currently approved or in development and what are the unique features of each of these agents. So these are the four agents in the US. Two of them are already FDA approved, the first and the second, that is teclistamab and elranatamab. And the two of them, that is linvoseltamab, which is the Regeneron product, and ABBV-383 or AbbVie product, they are still in clinical trial. Linvoseltamab is expected to be FDA approved sometime later this year. So I've written the manufacturers here. So teclistamab is as you know, is a Janssen product. It's the one that we have the most experience with because teclistamab has been around for a while and it was FDA approved also first, and then elrantamab was FDA approved later last year. The route of administration for teclistamab and elrantamab are subcutaneous, whereas linvoseltamab and AbbVie products, they are IV or intravenous. Teclistamab has a weight-based dosing, 1.5 milligram per kg body weight, whereas the rest of them are flat dose. The ramp-up schedule you can see is slightly different. I would like to highlight here that the ABBV-383 product, it does not have any ramp-up. So it basically starts as once a month dosing from the get-go with no ramp-up. So that's a benefit of that product logistically. We still have to see whether the efficacy and the toxicity kind of matches the other products as we get more mature data on that product. Then the frequency of administration, I think that's very important because for patients, coming once a week indefinitely is very, very difficult, not only from a physical standpoint, but also from a financial standpoint, especially in places where patients might have to pay out of pocket for these products. So the teclistamab, the way it's approved as per the FDA label, it's once weekly. However, we can switch to every other week once the patient is in CR for at least more than 6 months. So roughly at around 6 to 8 months, we can switch to every 2 weeks for most patients who are responding with teclistamab. With elranatamab, on label, it's once weekly for about 6 months, and then after that is every 2 weeks. With linvoseltamab, I think it's an advantage that it's once weekly until about 3 months, then every 2 weeks for about 4 to 6 months. But starting 6 months, we can switch to every 4 week if patient is in a VGPR or better and have had at least 6 months of therapy. So starting approximately 6 months, we can switch to every 4 weeks or once a month with linvoseltamab, whereas both teclistamab and elranatamab, it's Q2 weeks, so twice a month. And as I said, AbbVie is once a month from the get-go. I think one of the big disadvantages of these products is all of these have been approved as treatment until PD or progression of disease. So basically continuous treatment until progression. And we will talk more about it, why, that's problematic and what are the, toxicity and the efficacy pitfalls from that. But all of them have been approved. The way they're approved right now is until progressive disease. So next we will focus on the efficacy. How does the efficacy of these patients compare with each other? Now, I'll first say that all of these are single-arm trials, so there are no randomized control trials comparing one against the other, nor I don't think there will be in the future. So I basically have summarized the efficacy of these agents in each of those single-arm trial. So it's very hard to draw, like head-to-head comparison between them, but we can look at some of the things like VGPR or better rate or CR rate to kind of get a sense of the efficacy in these patients. So, the first thing I want to highlight here, that most of the patients in these trials were triple class refractory. And as I had shown you earlier in the first slide, these patients tend to have a very poor progression-free survival and overall survival once they become triple class refractory. So about, anywhere between 80 to 90% of patients in elranatamab, at least almost 100% of patients were triple class refractory. Then the median follow-up is very, very important because of two things. So first is the median follow-up is important is because when you look at the things like CR, complete response rate or progression-free survival, if the median follow-up is short, many of those patients, it takes time to clear the immunofixation. The CR rate may be low, or sometimes the progression-free survival may not be reliable because there is a lot of censoring going on early on. So the duration of response and progression-free survival, it may not be reliable when the median follow-up is short. Now for teclistamab and elranatamab, we have really good median follow-up, about 2.5 years for both of them. Both with linvoseltamab and the AbbVie product, the median follow-up you can see is roughly about a year. So we really need some more follow-up data, to kind of be confident about the results. So the overall response rate you can see is largely comparable, anywhere between 60 to 70%. And just to give you a comparison historically, when daratumumab was tested in a heavily refractory population to PIs and IMiDs, the overall response rate was roughly in the ballpark of 30%. And here, these agents are being tested in a triple class refractory population, and the overall survival rate is almost 2.5 times of that. So which is really, really impressive. And I think more than that is the most important thing here is that most of these responses are deep responses. It's not that we are getting only PRs or minimal response. Most of these responses are actually VGPR or better, and with the CR rate approaching 50% with linvoseltamab, but roughly in the ballpark of around 30 to 40%, overall. So it's hard to compare the products one against the other, but you can see a single agent complete response rate ranging anywhere between 30 to 50% is really impressive in this population. The MRD negativity rate, although I have reported it here based on the publications, but I would caution you against. So these are not intention to treat MRD negativity rate. They only checked MRD in patients who were quote unquote evaluable. That is, they defined that had a complete response or better, or a VGPR or better. And in those heavily selected population, the MRD negativity rate was very high, about 80 to 90%. But what we really need is the intention to treat MRD negativity rate, which is now the standard in most randomized controlled trials, thankfully. So hopefully, as we get more randomized controlled trials in earlier lines of treatment, we will get to see some of the intention to treat MRD negativity rate with these products. Then next, we will focus on more the long-term outcomes, that is PFS, duration of response, and overall survival. So again, these are single-arm trials, but as I said, with teclistamab and elranatamab, both of them have really long follow-up. So, the median PFS and duration of response, I would say, are pretty robust. And both of them, with teclistamab is about 11.4 months, elranatamab is about 17 months. And the duration of response at 2 year with teclistamab was about 50%, with elranatamab was about 67%. So, is elranatamab better than teclistamab? I think it's very hard to say, given, these are different trial, maybe slightly different population. To me, they are on the same ballpark. I would not prefer one over the other, based on the efficacy itself. And the median overall survival, roughly about, 2 years, here, both with teclistamab and elranatamab. As you can see, the median PFS with both linvoseltamab and ABBV-383, they're not reached. But again, they are very short follow-up, so we really have to wait for a little bit longer follow-up. Now, one thing that I would like to point here is the big gap between PFS and duration of response. So if you see with teclistamab, which has the longest follow-up here among all the four, the median duration of response is more than double the progression-free survival. And that's important because if you look at other drugs like, for example, daratumumab or even CAR T-cell therapy, you will not see such a big difference between median PFS and duration of response. And the reason it's the case is because with bispecific antibodies, there are a group of patients who will not respond to them and they will drop off immediately. The curves will drop off immediately. But those who respond, they seem to have a very durable response. And that's kind of the key here. And that's why you see such big delta between the PFS and duration of response with these agents. So to illustrate there, and also I will say that we should definitely exercise caution when comparing CAR T versus bispecific efficacy across trials. So on the left side is the PFS curve with CARTITUDE-1, which is the cilta-cel trial, the initial single-arm cilta-cel trial, and on the right side of the screen is the PFS curve from the MajesTEC-1 trial with teclistamab. And you can see with the CARTITUDE trial, cilta-cel, there is basically no immediate sharp drop in the PFS curve. And that's because these are not intention to treat analysis. These are only patients who got the cilta-cel infused. And once patients got enrolled, the time between the vein-to-vein time, the time between enrollment and the infusion of the cilta-cel product, that particular time, there are some patients who would drop off because some patients who might be very sick, whose disease might be progressing rapidly and they could not make it through the bridging therapy. And those patients will drop off and those will not be captured in the Kaplan-Meier curve. But in teclistamab, since it's an off-the-shelf product, we can pretty much start the treatment very, very quickly. And you can see that some of the sicker patients, they drop off, and you can see here a sharp drop in the curve between 0 and 3 months. And after that, there is still a drop, but slope definitely decreases after that. And that kind of is very important to keep in mind, when we are comparing these single arm trials of CAR T versus bispecific. And in fact, when we did a randomized control trial with CAR T cell therapy, which is the CARTITUDE-4 trial comparing cilta-cel versus standard of care, we did see that drop. You can see here, because it's an intention to treat analysis, patients between enrollment and cilta-cel infusion, there were patients who dropped off because their disease was probably exploding, or they just could not wait until the cilta-cel product. And many of those patients either progressed or even died, during that time. And you can see this sharp drop in the curve. So, we are really eagerly awaiting these randomized controlled trials of bispecific antibodies in earlier lines to compare with that of the CAR T. But you can see that with the single arm trial, it's very difficult to compare CAR T versus bispecific, especially when in CAR T cell therapy, they're not reporting intention to treat analysis, whereas in bispecific, they are reporting intention to treat analysis. Then the next, we will talk about the toxicities of the product, which is, very, very important. I think that's kind of the most important part of the talk is its toxicities, because these are double S4s. They have a really high efficacy, but also have significant toxicity. So the first thing, before even we go into the data on toxicity, I just want to, discuss some of the basic concepts about toxicity with bispecific antibodies first. So the first thing is that there is no plateau in infection risk with BCMA bispecific antibody when used as a continuous therapy. So since it's approved as a continuous therapy currently, as per the FDA approval for the products, we have to basically look at how the continuous therapy modulates the toxicities, and there is no plateau. So on the left side, you can see this is data from the Majestic-1 trial, I believe, where they looked at the number of infectious events per 100 patients across treatment. And you can see here that the grade 1 to 2 infection, grade 3, 4 infection, and grade 5 or grade 5 infections or infection-related deaths, they pretty much remain stable over time. So it's not that they're decreasing over time, they remain pretty much stable over time. And that's, I think, an area of caution, because if we are using these drugs as continuous therapy, we have to expect the risk of infection persistent over time, and we have to be very, very vigilant at catching and treating infections early. And on the right side, this is a real world study that we did. It was a multi-center study done in the US, where we looked at the cumulative incidence of infection, all infections, as well as bacterial, viral, and fungal, as well as all grade infections, as well as grade 3 or higher infections. And you can see here that there is no plateau again. The risk of infection continues to rise. One caveat with this data was that it had short follow-up. We'll be updating with slightly longer follow-up at ASH this year. But even with the longer follow-up, we are seeing that there is no plateau in the curve. The curves continue to rise over time. So with that background, we'll go into the infection risk with the BCMA bispecific antibodies. And again, here I would like to caution you that the median follow-up time is very important, because if you're looking at a single arm trial with a short median follow-up, like linvoseltamab or ABBV-383, which has much shorter median follow-up than teclistamab or elranatamab, you can have a falsely low risk of infection because the exposure time hasn't been enough yet for the infectious events to accrue. So that's very important to keep in mind, to look at the median follow-up when we are looking at the number of infections. So you can see the grade 3 or higher infections, is very, very high. It's about 40 to 50% with teclistamab and elranatamab. Again, with the caveat of short follow-up, linvoseltamab is already 40% at a median follow-up of 14 months, and ABBV-383 at a median follow-up of 12 months is 19%. Now, it seems low. Is it really that low, or is it just a small sample size and short follow-up? Time will tell. Now, one thing though is that with ABBV-383, its structure is slightly different in the sense that the CD3 binding affinity is lower compared to the other products. So one can make a hypothesis that because the CD3 binding affinity is lower, it may be that the T cell exhaustion from this product is maybe slightly lower, and also it's every 4 weeks. So all of that might factor in maybe having a slightly lower risk of infection. We really need to see long-term follow-up and slightly larger number of patients to see if that holds true. But so far, you can see with teclistamab and elranatamab about 50 to 60% approximately risk of grade 3 or higher infection. Death secondary to infection in teclistamab 13%, so really, really high. With elranatamab 6.5%, with linvoseltamab again short follow-up 4.3%, and with ABBV even at 12 months about 6.5%. Now, one thing I would say is that both teclistamab and elranatamab, they were done during the peak of the COVID pandemic. So it remains to be seen that whether in the real world, now that patients are usually vaccinated and the COVID pandemic has kind of waned off, whether the risk of death, it still remains that high. And also we are using more and more prophylaxis. So we really need long-term follow-up data from real-world studies to see how this translates into the real world. And you can see the grade 3 or higher neutropenia rate is also very high. It's about 66% with teclistamab, 50% with elranatamab, and also significant with the other two products as well. Now, how to mitigate the risk of infection? So again, we did this multi-center trial where we looked at something called as primary IVIG prophylaxis. So since teclistamab was approved and we started using it in the real world, from the trial, there was some data that, patients who were on IVIG, they might have had a slightly lower risk of infection. So many of the centers in the US, they actually started using primary IVIG prophylaxis, that is starting IVIG as soon as the IgG drops less than 400, which is typically by the end of first cycle, and without even waiting for an episode of infection. So just starting everybody from the get-go. And we saw that, again, it's retrospective data, not randomized data, but we saw that patients who were on primary IVIG prophylaxis, they had a significantly lower risk of grade 3 and higher infection compared to those who were not on primary IVIG prophylaxis in this data set. And the p-value was significant. And on the right side of the curve, this is the data from Mount Sinai, where they looked at all patients who were treated with the bispecific antibody clinical trial, and they looked at periods on IVIG versus periods off IVIG, and they saw a significantly lower risk of grade 3 to 5 infection in particular in patients during the periods on IVIG. So I will, transparently acknowledge that we do not have randomized controlled trial data, and we don't have strong evidence yet. But given the fact that we saw up to 13% risk of treatment-related deaths from infection with teclistamab, and these patients are so heavily pretreated and at such a high risk of infection, most of us in the US at least, we are currently using primary IVIG prophylaxis in the real world with teclistamab and elranatamab, given the high risk of infection-related deaths that we have seen earlier in the clinical trial. So these are some of the practical guidelines that we came up with in a paper in British Journal of Hematology. Again, many of these guidelines I will totally acknowledge they're not based on randomized control trial, but mostly based on retrospective data and also the combined clinical experience of many investigators who have enrolled numerous patients in these trials. So for bacterial prophylaxis, some centers are considering levofloxacin 500 milligram daily in the first month, and also when the ANC drops below 500 per cc for more than 1 week, because there is a risk of febrile neutropenia, unlike things like Revlimid, for example, which can cause neutropenia, but the risk of febrile neutropenia is almost close to zero. But with bispecific antibodies, we do see febrile neutropenia. So if the ANC drops less than 500 per cc for more than 1 week, we typically start levofloxacin in those patients. Then again, as I said, primary IVIG prophylaxis, starting the second month or towards the end of first month of therapy. At that time, most responding patients will have IgG drop less than 400, milligram per deciliter. Then viral prophylaxis, herpes simplex virus prophylaxis, hepatitis B prophylaxis if appropriate. And we do not use routine fungal prophylaxis, but we use mold active prophylaxis only if patients have persistent neutropenia. But routine PJP prophylaxis is absolutely critical because the incidence was up to 5% without prophylaxis. And once we have started using prophylaxis, the risk is now almost zero. So it's absolutely critical to use routine PJP prophylaxis in these patients. Then, I put CRS ICANS at the end because although I know CRS and ICANS gets a lot of press, but I think that's the least of my concern when I'm treating somebody with bispecific antibodies. That's in the top of my concern when I'm treating somebody with CAR T cell. But with bispecific antibodies, the risk is overall of severe CRS ICANS is very low. And as you can see across the board here, the risk of overall CRS is very high, anywhere ranging from 50 to 70%. But the risk of grade 3 or higher CRS is less than 1%. And we are seeing that also in the real world is about 1 to 2%. It's very low. Similarly, ICANS, most of the trials actually did not have any grade 3 or higher ICANS, and even the risk of overall ICANS is very low. It's less than 5%. And there was some report of peripheral neuropathy with the elranatamab trial. Again, it was a single arm trial. It's hard to know whether some of those were pre-existing versus whether those were caused by the drug. Most of the other did not report them. So I think it remains to be seen in the randomized trial whether it's a true signal versus it was just, many of those patients had prior exposure to things like Velcade and had some pre-existing neuropathy. And this is a retrospective trial, again, looking at the predictors of efficacy with bispecific antibodies, again, a retrospective trial from Germany. And all of these retrospective real-world studies have a limitation of short follow-up, so I would caution you against that. But they found that there are some things that predicted for a lower response rate as well as a lower duration of response, and mainly things like extramedullary disease, ISS stage 3, high bone marrow plasma cell infiltration of more than 60%, and prior treatment with CAR T cell therapy. All of these, predicted for an inferior response rate, duration of response, and progression-free survival. It remains to be seen, with the long-term follow-up, that how much is the difference in these. And then finally, what are the unanswered questions? Because definitely we are still learning about using them in the real world, and there are a lot of things we still don't know yet. So with that, one thing which is really very close to my heart is, a question that can we get the same mileage with finite duration therapy or with fixed duration therapy? So we did this study, which was recently published in Blood Cancer Journal, I think last week, in which we got a multi-center retrospective cohort together of patients with, patients who were on the early phase bispecific antibody clinical trials and who had to stop the trial because of a severe toxicity, for example, infection or severe neutropenia or a secondary malignancy. And, as long as those patients who survived those toxicities, that is, did not die from the toxicity and were able to live without disease progression for at least 3 months, we enrolled those in our retrospective cohort study, and we got a cohort of 23 patients after screening more than 200 patients across, I think, 6 academic centers. And we found that at a median follow-up of about 1.5 years, about 19 of 23 patients still remained in remission of treatment. That's very, very important because, many of these patients, they get a really bad infection, and then we have to stop treatment in those patients. And there's always a question that will the disease come back? And I think, we still need more prospective data, but at least this introspective data was very reassuring that just 4 out of 23 patients at a median follow-up of about 16 months had relapsed. And 19 of 23 still remained in remission. Also important to note that in the 16 months of median of 16 months of treatment-free remission, there were no deaths secondary to infection. And the longest a patient was in remission was 3 years. So imagine these are penta-refractory, triple-class refractory patients who were, almost about to get enrolled in hospice as the next step and did not have any other option. And now they're enjoying a treatment-free remission for up to 3 years. I think that's very, very important. And I think that's also a call to action to design trials testing fixed duration therapy to reduce not only physical but financial toxicity. So this is the LimitEC trial is doing just that. It's a trial being led by UPenn, Dr. Alfred Garfal, and we at Columbia are also participating in that trial. So in this trial, what they're doing is the patient starts teclistamab, and if they achieve a VGPR or better and have received at least 6 to 9 months of treatment, we enroll the patient in this trial and stop the drug. And at that point starts the treatment-free monitoring. So it's basically the monitored drug discontinuation. And we monitored the patients for an additional 6 months carefully. And the primary endpoint is basically whether the patients are able to maintain their response at the end of 6 months after treatment discontinuation. And then we follow the patients for a total of additional 2 years to look for the disease kinetics, whether the disease is coming back. And in those 2 years, if the disease comes back in some patients, we will plan to reintroduce teclistamab to see if we can get them back in remission. That way, they are not on continuous treatment. And basically, our hope is that this strategy not only will maintain the efficacy, reduce financial toxicity, but also reduce infectious toxicities, because we are seeing really bad infections, including infection-related deaths with continuous therapy in these patients. So more to come. It's a very early, and this trial will probably need another 2 years to completely accrue. But keep an eye out, in the next couple of years for the results of this study. Then next we will switch gears and move to GPRC5D, bispecific antibody. So one of them is already approved in the United States, which is talquetamab, and the other one, which is formitamig, it's still in clinical trial. So again, similar to BCMA bispecific antibody, both talquetamab and formitamig, the trials had a very high rate of triple class refractory population, roughly about 70 to 80%. Again, the overall response rate you are seeing is very, very high. The CR rate is roughly in the ballpark of 20 to 30%. So maybe slightly lower than what we saw with the BCMA bispecific antibodies, where it ranged from about 30 to 50%. Again, these are a different patient population. Many of these patients actually had prior BCMA exposure. So it's hard to know whether we can compare them head to head. But, at least looking at face value, it seems like it's slightly less efficacious than the BCMA bispecific antibodies. And the median progression-free survival, again, it has a very short follow-up of about 12 months. And the 1-year PFS was roughly about 35% with talquetamab. So, even at about 1 year, they already reached the median PFS. It was less than 1 year. If you remember from the prior slides, the median PFS with teclistamab was 11.4 months, and that with elranatamab was about 17 months. And the median duration of response with talquetamab was roughly ranging between 7.8 to 10.2 months. So with talquetamab, at least, we did not see a big gap between PFS and duration of response. Again, the follow-up is short. I think that we will see a gap with long follow-up, but I think it remains to be seen, as more and more data accrues on it. Then, as far as the toxicities are concerned, you can see that I did not have a separate slide on infection because infection is not one of the biggest toxicities with these agents. The CRS and ICANS gain is low, very similar to teclistamab and other BCMA bispecific antibodies. The overall rate ranging from 75 to 80%, but grade 3 or higher being pretty low is about 2 to 3%. The biggest toxicity here is the skin, oral, and nail toxicities, which are on target off tumor effect because of GPRC5D expression on the keratinized tissues, and also on the filiform papilla on the back of the tongue, and that's why it can also cause dysgeusia or lack of taste. And you can see here about 70% of patients, a very, very high proportion of patients, develop skin, oral, and nail toxicities with talquetamab, as well as with formitamic, and which is very problematic because it really impacts patients' quality of life. And although these are very, very efficacious treatments, the impact on quality of life cannot be ignored. And it's in my opinion, at least, that this will be a hindrance in getting these drugs in earlier lines of treatment. And I'll show you some pictures. This is from a case report that was recently published in a dermatology journal. You can see in the hands and the feet, the patients have this keratosis and complete peeling of the skin, and we see that all the time. Also, on the right side, you can see the nail changes. I definitely had patients whose nail completely fell off, both toenails and fingernails. And the lack of taste, that's very problematic. Patients cannot really taste anything. They lose weight. In a study from Germany, it was shown that the weight loss on talquetamab, at 1 or 2 months was, slightly more than what patients lose with MEL 200 auto, during the acute phase. So these are toxic drugs, even though these are, subcutaneous and outpatient administration, but very, very toxic. And, that may be a hindrance in getting these drugs in earlier lines of treatment, but no doubt they're efficacious. So, some of the key takeaways from the efficacy and toxicity of bispecific antibodies. So, for BCMA, I forgot to write that it should be BCMA in the first bullet point. The single agent overall response rate, both BCMA and GPRC5D, single agent overall response rate is about 60 to 70%, with majority being deep responses. With GPRC5D, the single agent CR rate is roughly about 20 to 30%. Responses seem durable, however, data is not as mature as the BCMA bispecific antibodies. Definitely, they have a lower risk of infection than the BCMA bispecific antibodies, but a high incidence of skin, oral, and nail toxicities with a negative QOL impact. And on the right side, this is another study that was published a couple of, I think, earlier this year, which looked at the risk of infection in patients who are enrolled in the clinical trials of these bispecific antibodies. And you can see in both these curves, the blue curve is basically GPRC5D as a single agent. And you can see with GPRC5D as a single agent has a really low risk of all grade infections and grade C or higher infection. But when you have a single agent BCMA bispecific, or you have a GPRC5D in combination with another agent, for example, daratumumab, the risk of infection really goes up in those scenarios. A question that often comes up now that we have both of these agents is that do GPRC5D bispecific antibodies work in patients with prior BCMA bispecific antibody or CAR-T? And this question was answered in an ASH abstract last year by Dr. Jakubowiak et al. And we don't have the paper yet, but as you can see here, the median duration of response was, the overall is about 12.3 months, and the response rate was pretty good, roughly about 70% in patients who had a prior BCMA targeted therapy. So, even patients who had prior BCMA, they responded really well to subsequent GPRC5D. The only subgroup where the response rate was lower was patients who had immediately like BCMA bispecific antibodies as a prior line of treatment. So if you see here, in patients who had prior BCMA CAR T cell therapy, the duration of response was 12.3 months. But in patients who had prior BCMA bispecific antibody, the duration of response was roughly half of that, was about 6.5 months, unfortunately. And, I don't know why is that. It could be that, the patients who move from a bispecific to a bispecific, maybe they are just frail, they are not CAR T candidates, or they might have really high disease burden or a rapid disease kinetics to the point that we don't have the time to wait for CAR T manufacturing. And we are just selecting those patients who are going to have a poor PFS no matter what. Or is it because of significant T cell exhaustion from the prior BCMA bispecific antibody that is also hindering efficacy with the future GPRC5D bispecific antibody? This was a very this was a very elegant paper by Dr. Nizar Balis's group from Canada, looking at the mechanisms of resistance to bispecific antibodies. And I think it has several lessons, as to how we can translate this data in the clinic based on what the mechanism of resistance are. So one of the big mechanism of resistance is T cell exhaustion, that is increased, exhausted CD8 positive T cells and lower frequency of effector CD8 positive T cells with these bispecific antibodies. So some potential solutions could be, like fixed duration therapy. Does fixed duration therapy mitigate the T cell exhaustion? Then question is that whether avoiding cytotoxic agents, for example, bendamustine, immediately prior to bispecific antibodies help preserve the T cell efficacy and prevent T cell exhaustion. Then the third is combining things like IMiDs or cell mods or even checkpoint inhibitors to bispecific antibodies. For example, there is a planned clinical trial of combining elranatamab with a cell mod, in a phase 2 trial. There is already trials ongoing on combining linvoseltamab or Regeneron product with checkpoint inhibitors in Europe. So I think, we'll see whether those strategies, are able to mitigate the T cell exhaustion and not only improve efficacy, but also will not add any additional toxicity over what we already have with bispecific antibodies. The next is tumor intrinsic factors. So, high tumor bulk has been shown consistently as a negative prognostic factor and a predictor of lower efficacy with bispecific antibodies. So, does prior debulking prior to bispecific antibodies help? Second is monitoring for antigenic loss. We still don't have any standard of care assay which we can use to measure, BCMA or GPRC5D expression. But in the future, if we have an assay like that, maybe checking the assay to see if patients have a robust expression before dosing the drug, can we use that as a biomarker? It of course has to be prospectively validated. And finally, dual targeting, for example, using TEC plus TAL together. These definitely sound promising scientifically, but it has to be shown in the trial that these don't add any undue toxicities or any unexpected toxicities over what we already have. And finally, the tumor microenvironment. And there are trials currently going on combining these agents with gamma secretase inhibitors to overcome the soluble BCMA sink effect. That is, first using the gamma secretase inhibitors to mop up the soluble BCMA in the blood so that, they are not acting as a sink to kind of bind to the bispecific antibody and preventing them binding to the myeloma cell. So again, these are all in clinical trials, not ready for prime time yet, and to be seen whether clinical trials really pan out and these agents are effective in mitigating toxicity. But I'll tell you that the one I am the most excited about among all of these is fixed duration therapy or finite duration therapy, because I think that will not only help improve efficacy, but also help improve the toxicity profile and also decrease financial toxicity in patients. Then finally, I just want to touch upon FCRH5 very, very briefly, given that it's not FDA approved yet. It's still in clinical trial very early. And I just saw a couple of days ago in the news that Genentech is apparently shutting down its cancer immunology research program. I don't know if that affects cevostamab. I hope it doesn't, because I think it's a good drug, but we'll see what happens with that. So, just briefly, FCRH5 or FC like receptor 5, it's a cell surface receptor expressed on 100% of myeloma cells. And, it's expressed on plasma cells more than B cells. And cevostamab is a humanized T cell engager bispecific IgG antibody, and it was tested in a phase 1 dose escalation expansion. The good thing is, from the get-go, they tested in a fixed duration schedule of 1 year. It was not continuous treatment, unlike both BCMA and GPRC5D bispecific antibodies. And prior treatment with CAR T cell therapy, bispecific antibodies, and ADCs were permitted in the initial trial. About 72% of patients were also triple class refractory. So again, very, very small number of patients, short follow-up, but CRS was 76% all grade, almost no grade 3 or higher, no deaths from CRS. Again, ICANS, all grade 1 to about 28% ICANS. Grade greater than equal to 3 neutropenia was 15%, so significantly lower than teclistamab. If you remember, that was about 50 to 60% grade 3 or high neutropenia. And the overall response rate was about 53% with the 20 milligram target dose, with a CR rate in 18%. You have to keep in mind that many of these patients have prior BCMA exposure, so they are different patients than the patients that were enrolled in teclistamab or elranatamab. And the ORR in the penta-refractory patients was 41%, and the ORR in patients with prior BCMA exposure was about 63%. So in ASH 2022, they did report an update of this trial in 16 patients who have completed the 1 year of treatment, and they found the responses were fairly durable. So first of all, only about 3 out of the total 16 patients, they have relapsed at latest follow-up, and the responses in 3 out of 16 patients that relapsed was VGPR in 2 and PR in 1. So none of those patients had CR. And 8 patients, at data cutoff, 8 patients had already sustained response for more than 6 months after completion, and 3 had sustained response for more than 12 months after completion. So again, it's short follow-up, but remains to be seen how much of the response is sustained. But it's definitely promising that they tested as a fixed duration treatment, and patients are able to sustain, a significant proportion of patients are able to sustain the remission treatment free, over at least intermediate term. And only 2 out of 16 patients had infection, pneumonia, and both were resolved in the treatment free period. Similar to in our retrospective study, in the median of 16 months of treatment free remission, there was no infection related deaths. So some of the key points here, that bispecific antibody targeting BCMA and GPRC5D are one of the most effective treatments in patients with triple class refractory myeloma, with a single agent CR rate of about 40 to 50% with BCMA and 20 to 30% with GPRC5D. The most problematic toxicity, I think, with the BCMA bispecific antibody is infection. Very important to continue these patients on triple prophylaxis, herpes simplex virus, PJP, and IVIG prophylaxis. The most problematic toxicity with GPRC5D is skin, oral, and nail toxicity. And CRS and ICANS risk is lower compared to CAR-T, especially high-grade CRS and ICANS, extremely, extremely rare. Finally, I want to add a couple more slides on the use of BCMA bispecific antibody in AL amyloidosis. So, first of all, philosophically, why is BCMA bispecific antibody an attractive treatment option in AL amyloidosis? So, my hypothesis is that patients with AL amyloidosis have a lower tumor burden than multiple myeloma. They have lower percentage bone marrow plasma cell. They have no extramedullary disease like multiple myeloma. And all of these features are associated with deeper and more durable response. Due to a lower tumor burden, the risk of CRS ICANS is likely to be even lower in AL. And we know that high-grade CRS and ICANS will be poorly tolerated in an AL patient population, which is already very frail and has multiple comorbidities. Due to a lower tumor burden, a less frequent or even a shorter treatment duration is likely to be sufficient in AL amyloidosis, potentially limiting toxicities such as high-grade infection, which again, there's a frail patient population, they're unlikely to tolerate high-grade infection well. And finally, the quick onset of deep hematologic response that we see with these agents is critical in AL. We know the time is hard. If we have a CR rate of 100%, but it takes 12 months to achieve a CR, that drug will not be beneficial in AL amyloidosis because, by that time, the heart, will continue to worsen. So the quick onset of a deep hematologic response that we see with these agents is very, very critical. And all of these features, I think, make us excited about the prospect of these agents in AL amyloidosis. So again, no prospective data yet, but there are 2 retrospective cohort studies now, kind of case series, you can say. And one of them we led in the US from Columbia and Medical College of Wisconsin, and the other one was a European study. You can see sample size very, very small. Our study has 7 patients, the European study has 17 patients. And you can see here the VGPR or better rate is roughly in the ballpark of 90 to 100%. And more importantly, the time to VGPR is measured in days here. So not even months, in days. So less than 1 month, most patients achieve VGPR. In our study was 18 days. In the European study was 28 days. So very, very short time to VGPR. No grade 2 or higher CRS, which was very, very reassuring. There was only in the European study, 1 patient had grade 3 ICANS, which recovered. But other than that, no grade 3 or higher ICANS. The median follow-up, though, is very short. In our study was 3.2 months. In European study was 3 months. We really need long median follow-up in these patients. But thus far, the risk of grade 3 or higher infection, it seems a little concerning to me, is about 30 to 35%. And again, these patients are very frail, so they can easily die from infection. In the European study, actually had 1 death, from infection. So I think it still remains to be seen as we are using more and more prophylaxis in these patients, whether the risk of infection goes down, and a fixed or finite duration treatment is very, very important, will be very, very important in these patients, because I don't think they can tolerate multiple grade 3 or higher infections. And these are the forest plot from these two. And on the left side is our study. All the red triangles are the time of onset of VGPR. You can see very, very short, again, measured in days, less than 1 month. Most patients are already in VGPR, same in the European study. And most patients, are continuing treatment and doing well. So with that, I would like to acknowledge the multiple myeloma and amyloidosis program at Columbia University, including our multidisciplinary amyloidosis group, all our funders. And I will also want to make a plug for our podcast, Blood Cancer Talks, where we, bring in different content experts across the globe on different topics in hematologic malignancies, and we have, another expert in myeloid malignancies and also lymphoid malignancies who co-host along with myself. And if you get a chance, check it out. With that, I would like to end and happy to take any questions.
Thank you so much, Dr. Rajshekar Chakraborty, for that fantastic talk. I think that was superb, I may say.
Thank you.
Depth of knowledge what we gained of bispecific antibodies, it is too much today. Fantastic.
Thank
And
you.
I request all our discussants to please put the raising sign so that we can start our question answer session. Yes, we have Dr. Ashish Dixit first. Dr. Ashish Dixit, your question, please.
Yes, really quite informative talk, I must say, Dr. Chakraborty. If Amit allows me, then I'll rather ask a few questions, not one question alone. So, in today's time, when all these antibodies are available, what is your choice of antibody to be used? BCMA versus GPRC5, because these are the two which are approved, or amongst the BCMA, which will be your choice of therapy if somebody is out of the without the clinical trial. We are talking about the scenario in India where we'll have to choose one of these in the beginning.
So yeah, I will tell you my personal opinion. Again, that may differ. So between different, myeloma physicians, so I would personally prefer BCMA over GPRC5D bispecific antibody first, just given the toxicities. I mean, you saw those skin, oral, nail toxicities can be very hard for patients, impacts their quality of life. With BCMA, there is a risk of infection, but now that we are learning how to use appropriate prophylaxis, the infection risk is we are seeing is lower in the real world, and it's tolerated very well. Like patients, it's like DARA. Patients don't even have any major side effects, once you start them. So I would personally choose BCMA first compared to GPRC5D. The only exception is if you are planning to use a BCMA CAR T, then you don't want to use the BCMA bispecific antibody first because, then you might, it's the same target, right? So you might compromise the efficacy of CAR T. In that situation, I would use something else, but sure, if you think that CAR T is not in the picture, is not available, or patient is not a CAR T candidate, then I would use BCMA bispecific antibody first. And the second question, among them, I think all four are the same. So far, we only have two of them available, teclistamab and elranatamab. Um, so we are using them interchangeably. I don't have any preference of one over the other. I think either one is fine. Logistically, elranatamab is slightly better for us financially for the hospital because it's providing us free ramp up dosing, whereas teclistamab, the hospital has to eat up the cost for the ramp up. So sometimes we use elranatamab because of that, but that's a totally financial. Like there is no scientific reason for to use one over the other, I would think.
All right. Will you prefer to use, say, any of the BCMA antibody when you are in the bridging therapy phase for CAR T?
If I'm using a BCMA CAR T, no, then I would not use a BCMA antibody as a bridging. Then I would, if I have to use a bispecific antibody, I would use a GPRC5D like talquetamab.
All right.
But yeah, or something else, like DARA or something else for bridging.
All right. So even after the CAR T, say, if you have done the collection already, will it still impact? That was a query. So that I mean, once we already selected the target and taken out for the processing, is it
Yeah,
really going to help? I mean, impact that much? The
that.
question was mainly pertaining to that if we have a low disease burden patient and we are
Mhm.
going to use CAR T cell in that scenario, will it not be as effective compared to those with the active disease?
So that, I don't think anybody knows the answer to that, but, I would think that if you're using bispecific antibody, even after collection, like during the bridging phase, it's possible that it may saturate the BCMA receptor on the surface of the myeloma cell. And maybe the CAR T cell therapy will not work well because the BCMA receptors are already saturated because these have long half-life. So that's the hypothesis, but I don't think there is any clinical data. But based on that possibility that there might be receptor target saturation, most people will not use BCMA bispecific antibodies immediately before a CAR T.
Right. Uh, as the second was mainly related to post CAR T and pre CAR T scenario. If somebody is not a candidate for CAR T or somebody who has relapsed after CAR T, which bispecific antibody you choose?
So yeah, if it's a relapse after CAR T after 1 year or so, after a significant amount of time, then I think it's totally perfection. It's perfectly okay to go back to a BCMA bispecific antibody. So in our real world study that we published, we did have a significant proportion of patients who had prior cilta-cel or prior ide-cel, and their response rate was the same. Now I don't know whether the duration of response will be same because the follow-up was short, but the response rate was the same. But if they're relapsing within 3 to 6 months of CAR T, BCMA CAR T, then I would probably use GPRC5D bispecific. I would switch the target because it's possible that their BCMA may still be saturated, the surface receptors.
All right. And if somebody is not a CAR T candidate, then in that case, I think I've already asked that
Then BCMA
question.
is first. Mhm.
Yes. Uh, so one more question was mainly related to our
Yeah,
country
sure.
only. We don't have the CAR T, CAR T available right now. Maybe another year or couple of years, we may not be getting. So, in that scenario, where do you place bone marrow transplant in a young patient? If I'm using bispecific and fixed duration I'm giving, I don't have a backup available if the patient relapses.
Yeah.
Where do you place and what time period of within 6 months? After 6 months only, I should do it. After 3 months or after CR? Any point of time? Any guidance that you can give?
So I would still do, I would still prefer upfront bone marrow transplant if patient is transplant eligible. So typically, like in the trials, 4 to 6 months of induction, and after that transplant. Now we don't routinely use consolidation in the US, so most trials use 4 cycles before and 2 cycles after. I tend to do 4 cycles, collect the stem cells, do one, 2 more, one or two more cycles, and then take the patient to transplant. And after transplant, start maintenance at day 100. So I would still use upfront transplant, and even with CAR T, we don't know because the randomized trial is currently ongoing, the CARTITUDE-6, comparing CAR T versus transplant. And we don't know whether that will be a positive trial or not. It will take a long time to figure out that, so, even the bispecific, even though we have bispecific, that would not really change my upfront approach at this point.
All right. And most of these patients are relatively older. I mean, comparatively, say, let's talk about somebody who is below 60 or around 60, 65, relatively fit. Uh, so in those scenarios, so what is your choice of conditioning if you're going to use transplant? Is it TBI based or non-TBI based that you'll prefer?
No, we usually use only MEL 200. We never use TBI. I think there was some old randomized trial comparing, I think, MEL 140 plus TBI versus MEL 140, and there was not much benefit of TBI. I don't know whether there is any randomized trial with MEL 200. I have to look that up. But yeah, we don't use TBI in the US or in the Europe, to my knowledge as well. We just use
All
MEL
right.
200.
And that's for the allogenic transplant.
No, auto transplant.
All right. No, my question was mainly pertaining to the allogenic transplant that where we
Oh,
do
okay.
place in a
Yeah.
young patient. The reason I'm asking is there are a couple of cases who are in 50s and having
Yes.
aggressive disease and primarily
Yeah.
refractory.
Yeah.
So they are good candidates for an allogenic transplant.
Yeah.
And we were trying to look at where exactly we can place it. So if those are the scenarios in very young patient,
Okay.
where do you put it?
So yeah, I will be honest with you. Like in my career so far, I have never done any allogenic transplant for myeloma. In US, we don't do it at all. Very very few centers still do it. So I probably will not be able to answer that question well because I never. That's usually not in our thought process. When we are seeing a patient in myeloma these days anymore. And some of the older physicians in the US, they will probably have experience with that. Like I know Dr. Hari, has a lot of experience with allogenic transplant in myeloma. But yeah, I don't. I've never done allogeneic transplant in myeloma so far.
All right. Uh, then for bispecific antibodies, somebody who is responding very well, what's the duration of IVIG that you are going to use? Means
So
as long as the bispecific going on or when you stop the maintenance also, if it is, say, it's a continuous therapy, do you
yeah.
stop IVIG at any point of time?
So we stop only once the patient's IgG recovers. As long as the IgG is less than 400, we will keep going. So let's say in some of my patients I have stopped, they had a bad infection and the teclistamab was stopped. And after that they are in remission, and then I continue the IVIG, but at that time sometimes I stop the IVIG for a month to see if the trough IgG level the next month is still less than 400 or not. If it's still less than 400, then I keep going. If it's more than 400, then I stop it and wait until the trough IgG level to go less than 400 again. So it's kind of individualized from patient to patient. But I can tell you that even after stopping teclistamab, most of my patients are still needing IVIG for months and months because it takes a long time it's taking for the IgG to recover.
All right. Uh, and last question is mainly related to the role of your use of prophylactic tocilizumab in the step-up dosing. Are you using prophylactic and OPD-based teclistamab administration, or it is still
Tocilizumab.
inpatient?
Yeah, no, so we are still doing inpatient, but I know many centers in the US are doing outpatient. But prophylactic TOSI, there are some data, single arm data, showing that it might mitigate the risk of CRS. So how I am using is if I have a very old patient who is frail, who may not be able to tolerate CRS well, in those patients, I'm sometimes using tocilizumab before the second ramp up dose. Or if a patient has a really high tumor burden, I'm worried about them getting a really bad CRS, then I'm using tocilizumab before the second ramp up dose.
Sure. Thank you very much. Thank you. It's really helpful.
No worries.
Thank you, sir. Dr. Roshni Pandey, ma'am, your question, please.
Good evening. Thank you for that very wonderful talk, which covered most of the points and the questions which have preceded me. The first question is what is the role of delayed autologous transplant when someone has never received transplant? Do we sequence it always before CAR T cells, or it is mostly done before CAR T cells in multiple myeloma?
Yeah, so if patient did not receive transplant, upfront, then as per the randomized trials, both IFM and determination, we are doing autologous transplant at first relapse. So, right now it has changed a little bit because in US, as you know, cilta-cel, the BCMA CAR T, is approved now in first relapse. So right now, some of my patients who did not get transplant upfront, when they're relapsing, we are having that discussion that whether they should get, some like induction treatment and then autologous transplant, or they should directly get CAR T. And I would say it's a patient to patient discussion. I discuss with the patient the side effects of CAR T, side effects of transplant, and with CAR T, we still have some of the side effects which are new and we are still learning about it, like the Parkinsonian toxicity, facial palsy, and things like that. Whereas auto transplant, we are really comfortable. We've been doing for years and years. So I would say that some patients are choosing auto transplant and keeping CAR T in reserve for the next relapse, and some patients are choosing CAR T. So I think there is no data for me to say one is better than the other in that scenario. But I personally, given that we have so much historical data with auto transplant and we know the auto transplant is really effective, I personally, try to, in those situations, I try to reserve CAR T for the next line because we don't think either of them will be curative and patient will likely need all of them. We don't know whether auto will work down the line, but we know that auto does work in the first relapse setting.
The second question is, when you say that a patient is not a candidate for CAR T cells, do you mean it's only the age and the performance status frailty, or is it something else also?
It's mainly age and performance status, frailty. I mean, there is no objective criteria. It's mostly based on like physician to physician, and I mean institution to institution. We have done CAR T. I think the oldest we have done in our center was in low 80s, even, who was fit otherwise. But definitely slightly older than patients who undergo auto transplant. But still, these patients can develop significant toxicities with CAR T who are older patients. So it's mostly subjective decision.
And is there any role of BCMS bispecifics along with DARA or pomalidomide if those have not been used before, or if there's a long disease-free interval, or they
You mean
are sensitive to DARA or POM?
So you mean a combination, right? A combination study. Yeah, so we have clinical trials currently ongoing with that. We have a clinical trial with BCMA bispecific with DARA or BCMA bispecific with carfilzomib. It's still very, very early, so we don't know whether it will be definitely slightly more efficacious, but the main concern is, will it add significant toxicity? Because there was a small study from, I think, UK, where they had 32 patients who had teclistamab and DARA, and there were, I think, 2 or 3 deaths, from infection. So that's a significant number. So it still remains to be seen whether those combinations are safe. So I would not do it outside of a clinical trial yet. I think I'm still concerned about the risk of infection and deaths from infection.
And since BCMA bispecifics cause infection and T cell exhaustion, so modifying the dose schedule, you mentioned limited, duration, but modifying dose schedules, does it help?
It has been shown in the clinical trial that changing to every 2 week or every 4 week was associated with decrease in the risk of infection, but it's hard to know and hard to be sure about those data because those are not randomized data. and patients who stayed on the trial and decreased the dose, maybe those are just healthier patients. Maybe the sicker patients are already kind of off the trial by that point. So it's for me, it's very hard for me to get my head around that data. I think we don't know yet. We are doing it with the hope that it will, but I think finite duration is likely going to be the answer. But we'll definitely need randomized trial for that.
So this finite duration would mean 6 months, less, more, or don't know.
So the Limitech trial, which I showed, that is doing 6 to 9 months. So it has given a window of 6 to 9 months. That is the only trial that I am aware currently, which is testing a finite duration. As you can understand, that pharma companies are not interested in that question, right? They want to give the drug as much as possible. So it's very hard to do those trials. But thankfully, there is one trial ongoing. So with that trial, we'll get some information. And the plan, as far as I know, is that there will be a future. If that trial is successful, it will lead to a future randomized trial.
Thank you so much.
You're welcome.
Thank you. Dr. Ashok Mishra, your question, please.
Good evening. Thank you very much for a very elaborative lecture on bispecifics. So these bispecifics associated with lot of infections. So my question is regarding pre-treatment screening of a viruses. Second is besides prophylaxis of a pneumocystitis and herpes, any other prophylaxis is required? And third is regarding vaccination. Should we considering vaccination before giving bispecifics?
Yeah, those are very good questions. So we do, in the US setting at least, we are not routinely doing a full viral screening like we do for allotransplant, for example. Like CMV, BV, all of them. We are not routinely screening for that yet. We are just doing the hepatitis B screening, hepatitis B and hepatitis C. In the Indian setting, maybe checking for quantiferon, maybe like for latent TB might be important. Yeah, in the US, it's not that prevalent, so we are not doing that yet. For prophylaxis, we are using HSV prophylaxis, PJP prophylaxis, and IVIG. And on a case-by-case basis, entecavir for hepatitis B if patients have a core antigen positive. What was your other question? Vaccination, right? So
Vaccination.
most of these patients actually who we are using this on, they're already coming after DARA. So they're already very immunocompromised coming into the teclistamab. So we don't think at that point that they will really respond to vaccination. But if we think that they will, then we are definitely not doing live vaccination, but the flu vaccine or the COVID-19 vaccine, if they have not gotten it before, then we have the RSV vaccine now in the US. We are doing that as well. Those we are giving before the teclistamab. But again, most of these patients, they might not respond to them because they are already immunocompromised from prior treatments.
Okay. Thank you. Thank you very much.
Thank you, Dr. Ashok Mishra. Dr. Tejaswini, your question, please.
Good evening, sir. My question would be, what is the difference between progression-free survival and duration of response? That was not clear.
Yeah, no,
I could not understand what it is.
Yeah, so progression-free survival is like everybody who starts the drug and then they have and then they are basically followed for two events, either disease progression or death, right? So if they have one of those events, they drop off. So that's typically progression-free survival. For duration of response, it basically only includes patients who have a response. So patients, let's say in the first 3 months, who died without a response or whose disease progressed and they came off the trial, they will not be in the duration of response curve. Only those patients who survived the first couple of months, had a response, only those patients. And then once they had a response, that is their day one, that is their T0, and then the duration of response. So basically, the big gap shows that with teclistamab, there are some patients who will not respond to it and they will drop off immediately, either due to progression or due to death. But those who respond, their duration of response is very long. So that's I think an important information for the patients to know, that once they respond, it's not very helpful to look at the PFS curve because their numbers will then more likely mirror the duration of response curve and not the PFS curve.
Any other question, Dr. Tejaswini?
Sir, it was very clear the way sir has explained.
Thank you.
Thank you. Thank you.
Well, so there are no more questions from the audience also. Anybody else want to ask any other question to Dr. Rajshekhar Chakraborty? Okay, so there are no more resident signs. Sir, you're fantastic, superb. I think you cleared all our doubts on bispecific antibodies. Today was a very detailed discussion. We had heard about it, but today we came to know what exactly it is about. Thank you so much, sir, for a fantastic lecture, superb understanding, and a wonderful discussion. And I again thank you for accepting our invitation as a speaker today. Thank you so much. And I also thank all our discussants as well as audience to participate in this webinar. Meet you tomorrow at sharp 11:30 a.m. with another beautiful webinar. Goodbye for now. Thank you so much, Dr. Chakraborty, once again.
Thank you.